Welcome to this session. My name is Gustavo Higuera. I represent Solutex, and I will be moderating this session. I want to start by thanking the organizers and our host, Atlético de Madrid, and also our guest, Dr. LeMay, for making the trip to talk to us today. We're very lucky to have him. And I'm going to start with a story. It is extraordinarily difficult to sell products to professional athletes. And this product that you have right here is not being sold to just one team. It's being sold to teams in the NFL, NBA, NBL, NHL, to the Big Four in the USA. And part of that success is actually having a person that is trusted by the players and by the teams to carry on the message on how to use the product, like professionals like Dr. LeMay, who is giving advice on how the product should be used, and that advice is being taken and being acted upon. So the other factor, actually, that is important for that is having a product that works with efficiency. And that's the part that I'm going to focus on a little bit right now for the next 3 minutes to tell you a little bit more about that. So Solutex was founded 20 years ago. Actually, this is our 20-year anniversary. And we are leaders in the omega-3 industry worldwide. And the business of Solutex has been defined by two breakthrough innovations. One of them was the use of supercritical CO2 to concentrate oils and to be a distributor, to be a manufacturer of omega-3s worldwide. And the other one has been in the ability to concentrate the active components of omega-3s, which are called SPMs, Specialized Pro-Resolving Lipid Mediators, which is what we are going to be talking about today. Azur is the affiliate created by Solutex to distribute these products that have a high concentration of SPMs. And it is actually based on and inspired by the science of researchers such as Dr. Charles Serhan of Harvard University, which you see in this picture with his team. He's a highly cited researcher, and he's inspired a generation of products that we are talking about today, for example. And we have also invested in a laboratory in Zaragoza, in Spain, where we can measure in different tissues the quantities of SPMs, and to be able to make decisions as to how to use the products, how to best develop them, and how to give the best possible product to our customers. And Sports ProResolve was launched in 2018 and in the USA. And since then, the first adopters of the product have been professional athletes, such as in the MLB that you see here, and in the NFL, like Matt Ioannidis, where they repeatedly say, I just feel better. It just makes me feel better. And we try to understand actually what is that makes him feel better. And well, that's why we have invited Dr. LeMay today to speak about how the product is used in the USA and his own experience as a practitioner with all these different teams and players. Dr. LeMay is board certified in physical medicine and rehabilitation, and also has a board certification in metabolic and nutrition medicine, has completed a fellowship in anti-aging and regenerative medicine. He's an associate clinical faculty member at Florida State University, as well as being visiting faculty for the Institute of Human and Machine Cognition. He's the chief medical officer for JAG Consulting Group. He has served on the Exos Performance Nutritional Advisory Board. He's the medical director for the NFL Players Association Trust Breakfast Club through Ixos, and is a member of the NFL Players Association Pain Committee. He was a member of the medical staff for the Washington Wizards and on performance staff with the Oakland Raiders. He is currently on the performance staff with the Washington Capitals, St. Louis Cardinals, Oklahoma City Thunder, and the Hershey Bears. He has been a consultant with the Utah Jazz, Washington Mystics, and Toronto Blue Jays. Please give it up for Dr. LeMay.
So in discussion and kind of setting the stage for understanding why it is important to have resolution, I kind of want to talk through basics of human performance and how I think through things physiologically. When we're trying to achieve performance, part of our goal is obviously the overall ability of the athlete to perform, but also not to break down. That's a big key. And in terms of how I think through things in a model form, your genetics are what I would describe as the loaded gun, and everything around your genetics is going to pull the trigger. So we can't change what happens with genetics. We might be able to change what's expressed, though, through these other factors. And so when we are, as part of a performance staff, trying to make changes, we focus on sleep. We focus on stress and resilience. We're looking at ways to make sure that our training is efficient for the athletes so that they're getting gains and not breaking down. Nutrition is a big key piece to this, and there's many layers to the nutritional side of things. I'll just touch on those when we get there. And then there's environmental exposures, and you can't always control all of these, but these factors will have an effect at a cellular level on three basic functions. And within each compartment of the body, whether we're talking about the brain or we're looking at muscle or we're talking about cardiovascular tissue, these three factors are important no matter what compartment we're looking at. And energy production or mitochondrial function is one of those. And so you will see sometimes devices that are used to try to help mitochondrial function, things like red light therapy. We might use supplementation to try to help with energy production at a cellular level. So this goes beyond just calories in and calories out. Oxidative stress is another big factor, and there's a lot of discussion in the sports community about antioxidant use. Do we give it to athletes? Do we avoid it with athletes? And when should we do, which one? We don't want to basically overextend our external input so that we suppress, completely suppress oxidative stress because then we don't get an adaptive training response. And then inflammation. And unfortunately, all of these things will tie back to inflammation, and our understanding of inflammation has been flawed. So for decades and decades, what we've been doing and the way that we think about inflammation, unfortunately, isn't correct. So our thought process on how to block inflammation, you'll see, is problematic. So if I just look at and pick an injury as an example where you see all these things tie together, concussion is a great example. So in concussion, you have the primary injury, which is the bruising. So you'll have coup contra coup injury. You actually have cavitation injury, which is sort of a newer concept that you're beginning to see show up in the literature. And you get axonal shearing. So you get damage to the connections between the nerves that creates a response at the membrane where you're seeing an efflux or influx of certain nutrients like calcium and potassium and even magnesium within these, what we call NMDA receptors, excitatory receptors. The end result of that immediate response to the injury is what we call the secondary injury, and that is inflammation, energy production problems, and then oxidative stress. So you start to cause problems with the mitochondria. And when that happens, then you create an energy insufficiency state. Blood flow plays a role there too, but that then leads to oxidative stress. Oxidative stress will lead to cell damage markers that you can see, like lipid peroxides, and there are markers that we can measure, at least within the US, that look at DNA oxidative stress as well. And so you can see some of these show up. But in the brain, when you see these markers show up, this is activating your central nervous system, particularly your microglial cells, which are involved in repair. So your immune cells in the brain then respond to this inflammatory response. And the end result with this, if it's not shut off, is you have cell death. So this can be applied to basically just about any situation that you want to look at. And we see a lot of times with people with concussions, they have sleep problems. One of the mechanisms is related to the secondary injury of concussion, which is inflammation, oxidative stress and energy production problems. It just happens to happen within the centers that control sleep. But you'll see that when the sleep center is interrupted, then there's a problem with healing. So what about the impact of nutrition? The initial layer that people have to look at is calories. So calories in, calories out. And I know people that just focus on that. If you are too insufficient in terms of calorie load, you begin to break down. You change what happens with the endocrine system. And so I won't go into full details of that, but that's a whole other talk, but they have a significant impact on your ability to repair. And then you have macronutrients, proteins, carbs, and fats. And you need all of these, and people will argue sometimes over the types of fats, for example, polyunsaturated versus monounsaturated versus saturated. But even within each compartment of those, you might talk about saturated fats. There are certain saturated fats that act completely different than other saturated fats. So each one can be broken down into a micronutrient component, which is important in pushing all of these chemical or biochemical pathways. So if you are missing the micronutrients, you can't generate the chemistry that you need to form normal pathways and to affect the body in a normal physiologic pattern. Stress has a negative impact as well because it's going to decrease your absorption of these micronutrients, which leads to problems. And to touch on the relative energy deficiency state in sport, we see this in men, we see it in women. 20 years ago, we said this happened in women, we ignored it in men, but it happens in men. So if you're calorie insufficient or you have an energy production problem, even at a cellular level, if you have a mitochondrial problem, you can end up in a state where you'll see hormones drop and then your anabolic function will begin to change. And why does anabolic function work for us? A part of it is going to be a pro-resolution effect, which we'll kind of talk through. With oxidative stress, there's an imbalance between what our body can handle with generation of free radicals and our antioxidant capacity. So that's both intrinsic, what we produce ourselves, and extrinsic, which is what we would get in the diet. And in terms of the intrinsic pathway, our goal is to produce glutathione, and this requires, again, micronutrients. So if I'm in a stress state, and let's say I like to drink alcohol after games, I'm taking nonsteroidal anti-inflammatory medications, which can deplete some of these nutrients, I can end up in a state where I'm having difficulty producing glutathione. Oxidative stress goes up, I impair some of these enzymes like tetrahydrobiopterin, which I need to produce nitric oxide. Well, I want blood flow to an injured area, so that's a problem, and then it affects our neurotransmitters, so things like dopamine, which I need for motivation and drive, and serotonin is also part of that reward system. So these are all affected and interconnected. Multiple different things that you can have in terms of environmental exposures that can lead to oxidative stress, which can therefore then trigger an inflammatory state or a chronic inflammatory state, which causes a gradual breakdown over time. Stress, we talk about allostasis versus allostatic load. You can have too much stress, whether this is physical or emotional, and your body begins to break down. So a little bit of stress helps our performance. We get better and better up to a certain point, and then we begin to have a decrement. So why do we have a decrement? Because we can't keep up with the physiologic demand in these allostatic load states. We can't basically keep up with the repair nutrients that we need, but we also get into a chronic inflammatory state with this. So what you'll see in terms of hormone response oftentimes, and you'll see this as something that has been looked at for a period of time, is seeing what's happening with cortisol. And you'll see people measure cortisol and try to get a judgment on what's happening internally with the allostatic load. Cortisol goes up with response to stress and it breaks things down for fuel. And if you're breaking down body fat, that's okay. But if you're breaking down muscle and ligaments and tendons and you're losing bone density, that obviously is a problem. It increases your risk of injury. This will have an impact on your immune system with high cortisol, and once DHEA begins to drop off, a lot of times you'll start to see a suppression of other anabolic hormones like testosterone and growth hormone. So they're all interconnected, and we've been seeing for at least 20 years that there are common mood disorders that you see within athletes, and related to the sympathetic and parasympathetic nervous system. So your ability to balance this is important with your athletes. But a lot of what we really have to focus on is that these things will oftentimes work through the cellular mechanisms that I discussed. And part of that is the inflammatory response. So inflammation links most of these things together. And if we're looking at injuries in general, there's two ways that we can handle things internally that you see with an athlete, right? So you strain a tendon. Tendon can go on to a healed state. The tendon can also get to a state where it's in a chronic breakdown state, and then you gradually see issues like tendon ruptures. And we see this, I see this sometimes with teams that I've worked with where they'll bring me into a situation saying, we don't know why. We have no idea what's going on with this guy. We've tried collagen, we've changed their workouts. We don't know what's going on with this athlete, but they've created this sort of chronic degenerative state and their tendons are starting to break down. So a lot of this has to do with a chronic inflammatory state. And what we've done with inflammation, unfortunately, has kind of been misguided in terms of how we handle it. So the old thinking is that you have inflammation is bad. If we block inflammation, then we've helped the athlete or we've helped the patient. And the goal of inflammation, or what we want to have happen, is to get rid of damaged tissue. That's what it's there for. So what you see is the cardinal signs of inflammation are going to be things like redness and heat, pain and edema. If you look at a cellular level, you're going to see cellular changes within the immune system, which controls this, like neutrophil infiltration, macrophages, and monocytes. And there are changes that happen with these specific cells that get us out of the destructive phase and into the healing phase. So the goals of the acute inflammatory response are to eliminate the initial cause of injury, remove necrotic tissue and debris, and initiate the process of repair. So this is our old model. This is what we think of, and you can see at that the diagram on the bottom right, there are lots of medication interventions that we can look at to block some of these pathways to change what happens with inflammation. So we're converting omega-6 fats into compounds that are active fats, like prostaglandins. And we need some of these compounds to have a healing response, but you can see here with cyclooxygenase, or COX, we're converting arachidonic acid into prostaglandins, and you'll see that involved in the edema phase and then in the recruitment of neutrophils, and then followed by that, you'll see the macrophages and monocytes come into an area. So I've seen a shift in the pro sports community, particularly with the dietitians who are more forward thinking, saying, hey, we've got to do something different than our old mechanism, but it's still the same model that's being used oftentimes that needs to shift. So we've shifted from just block inflammation, give everybody ice, and give them NSAIDs. And that's kind of been the model, or give them things like a steroid pack, a Medrol dose pack, or prednisone, or something along those lines. Some of the natural compounds that you might see used, curcumin, boswellia, and I just picked a bunch. I mean, not any specific reason, but bromelain, which has a different pathway or mechanism than some of the others, capsaicin for pain, balancing omega-3s and 6s, that's an important one. Ice, CBD. I could tell you within the NFL and the NBA, even though marijuana is considered a banned substance within those leagues, about 80% of the athletes use it. So if they enforced those rules, they wouldn't have a league, so they don't. But what a lot of these athletes kind of give as an anecdotal response is they heal faster with it, or they have less problems with anxiety when they're using them. So I discuss it, although I'm not promoting the use of any of this within an athlete. And then, of course, we have our old standby, which is non-steroidal anti-inflammatory medications. And within my primary field in physical medicine, if you grab a textbook for PM&R and you look, any type of injury, what is first-line standard of care treatment? Non-steroidal anti-inflammatory medications. Unfortunately, it is completely contraindicated from a scientific evidence standpoint, and we'll kind of go through that. It's just what we've seen in terms of the scientific literature has changed, but medicine has not yet caught up to what the scientific literature is saying. They will, but it hasn't quite happened yet. But what you won't see is evidence that non-steroidals help with healing. So it makes it interesting. So if we do evidence-based medicine, we want to look at, okay, evidence. What does the evidence say about non-steroidals? Well, they help with pain. Well, that's a good thing, but not necessarily with the healing response, which we'll keep saying we'll get to it, but we will. So what happens is you have an inflammatory response, and then you have an active phase, which is a resolution response. So we used to think of the active response as just inflammation, and then passively things magically heal on their own, or are allowed to because they were being inhibited by the inflammatory response. And the resolution or the healing response is triggered by these resolution mediators. So if we have this acute inflammatory phase that is happening, the ideal outcome is a complete resolution, healing, and a protective mechanism on healthy tissue. That's what we're after. So we want cessation of the inflammatory response without a chronic degenerative response. And that comes down to 4 families of fats that are active fatty acid compounds. You have lipoxins. Those are the only ones that we know of so far that come from omega-6s. So omega-6s will produce prostaglandins and thromboxanes and leukotrienes, depending on the enzyme activation. But lipoxin A is a pro-resolution fatty acid. And then we have 3 families that come from EPA and DHA, from omega-3s. And these are the resolvins, protectins, and maressins. Similar mechanisms, a little bit different cellular functions, but this is what triggers the healing response, is the ability to do this. So these will have an effect on what happens with mitochondrial RNA production. So mitochondria are affected by these and have an effect on their production. They affect proteins, so things like cytokine production within the body. We talk about things that are, quote, anti-inflammatory in terms of cytokines like interleukin-10 versus the more pro-inflammatory things like interleukin-6 or TNF-alpha. Some of this is controlled by the resolution process. And then you have lipidomics, which is what we're kind of concentrating on here. So these SPMs control the process. And the cardinal signs, again, of inflammation, you can have things like fever, redness, edema, pain, but loss of function happens in an inflammatory state. And our goal in human performance, what do we want to see with our athletes? Well, we want to see removal of necrotic debris. And a lot of the tools and mechanisms that you see that are trying to encourage this are actually pro-resolution in their nature. So we want removal of necrotic debris. We want restoration of function. We want regeneration of tissue, which happens, again, stem cell production and production of a healing response, satellite cell recruitment. This happens because we are able to produce resolution mediators. And then you have relief of pain. So what's my goal if I'm part of the medical staff or I'm part of the performance staff? What's my goal with the athlete? Well, I want to get rid of pain. I want to get rid of damaged tissue. I want to rebuild and I want to repair. That's what we're after. And so most of the tools that we see being used, even injectables, what would I use PRP for? What do I use exosomes or stem cells for in terms of injection? What do I inject collagen for? These are all things that actually should be promoting a resolution response. That's under the definitions or terms, that's what we're actually after. So these specialized pro-resolution mediators have been studied and their effects have been looked at in the molecules. As we're finding more and more molecules that are active compounds, we see they branch basically from EPA and DHA, and there's some that come from DPA as well. But the resolving criteria for these is to reduce the pro-inflammatory cytokines and their counter-regulation, and reduce eicosanoid storms. That's what we don't want because that's what's present in a chronic inflammatory state. Enhance neutrophil clearance and bacterial killing, so they actually help things like antibiotics work better, may decrease the need for use of antibiotics, and help decrease infections. I mean, one of the things that we see with teams, our dreaded thing that we see in the wintertime with travel is with the NFL, we see this, with the NBA, we see this, NHL. If one person on the team gets sick, everybody else gets sick, right? So we're looking for ways to try to curb that or have less of an impact. Vitamin D has a positive impact. But resolution is one of the key ways that we can promote bacterial killing and viral killing. We want to stimulate phagocytosis of neutrophils to clear them out of the area once the initial damaged tissue is removed, and increase the debris via the lymphatics, and then obviously reduce pain. So those are the criteria for calling something a resolution mediator. So if our goal is to get to wound healing and not to organ fibrosis, we have both an innate immune response, which is our initial response with neutrophil infiltration, and we have an adaptive immune response, which is where we eventually want to get to. We can't get to that adaptive immunity without production of resolution mediators. And this requires all the things that we were talking about. So we want hormones to be present in the right amounts, particularly not an imbalance between catabolic and anabolic hormones, because we want to get to a resolution state. That's what we're ultimately after. And when we talk about chronic disease states, this is actually a slide that Dr. Sirhan sent me to incorporate with these with talks, but we'll see chronic problems with the ability to produce resolution mediators show up in all of these different diseases. These are things that have been studied in humans. So atherosclerosis, or cardiovascular disease, autoimmune diseases like dry eye, this has been studied, periodontal disease. Smokers don't produce resolution mediators. And just about any kind of chronic disease state that you can name, they have higher incidence of. Alzheimer's disease, obesity with diabetes, the resolution response is impaired. So what can happen? Why is it impaired? Well, it could be an imbalance. We don't have things in the diet that would normally push the resolution response. It could be a problem with biosynthesis of enzymes. That could be nutritional as well. SPM receptor deficits and genetic factors also play a role here. COVID-19, this was a big one, obviously, for all of us. That we went through over the last few years, the inability to achieve a resolution response was central to the chronic COVID cases and the more severe cases. This was a slide from about 6 years ago looking at the initial resolution mediators and some of their cellular responses. And you'll see in maressins and resolvins and in lipoxin, all of them reduce pain, but they change what happens in terms of the cellular response and in terms of the cytokine production. So our thought process has been think anti-inflammatory. That's what we've been kind of trained to think. How can I be anti-inflammatory with somebody? But the reality is that if I'm anti-inflammatory, what I may end up being is pro-chronic inflammatory. So if I'm blocking inflammation, I'm not necessarily helping the problem. And one of the ways that I describe this to athletes, I work with the Oklahoma City Thunder, and this is one of the teams, and I had somebody kind of looking at me funny when I was discussing the use of resolution mediators. So our center is a big guy. He's 7'3", he's listed as 7'1", he's 7'3", probably because he hunches down a little bit, he looks shorter than he is. But when Chet was talking to me about this, he said, I don't understand the difference. And I said, okay. So let's say that Mark Daigneault decides that I'm going to play center tonight because we had a game against Milwaukee, just a preseason game. And he kind of smirked. And I said, yeah, it's pretty funny because there's no chance that you guys could possibly win a game if I'm playing center or point guard or shooting guard or small forward or power forward. I'm not going to be helpful in any position on the field. I'm probably more of a safety cone on the field, and that's about as good as I could do. So you want to get me off the court as quickly as you can. That's what inflammation is supposed to do. Get me out of there, because I'm a weak link. Our immune response, or our immune system, is scouring for weak links, and it wants to get rid of them. So that's inflammation. We need that to happen. But we need resolution too. You got to replace me with somebody who can play. So let's put Chet back in the game and let him play his position. Then we have a chance of winning a game. So that's the way I kind of describe it in terms of how to relate to athletes, and then they kind of understand, it kind of clicks with them. Again, omega-6s, the lipoxins are the one area in terms of omega-6s that are potentially pro-resolution, and they cause the switch that happens where immune system stops focusing on using cyclooxygenase to convert omega-6 fats and starts focusing on converting omega-3 fats. And so if we have sort of the typical Western diet, far worse, I would argue, in the United States, the North American diet, we have a ton of omega-6 fats in our diet, probably a 30 to 40 to 1 ratio of omega-6s to omega-3s, and that's a problem. And that's been looked at in cardiovascular disease and other disease processes. When you change the ratio, you help a little bit in terms of the healing response. But you need these families to be produced in order to have a normal healing response. So if we look at NSAIDs, why are NSAIDs a problem? Well, if we're blocking cyclooxygenase, which is a key trigger for these responses or these pathways, I'm shutting down both. I'm shutting down not just the inflammatory response, but I'm shutting down the resolution response. So I get a blockade of what should be happening in terms of a healing response. So I'm going to see a chronic degenerative problem ensue because of the chronic use of nonsteroidals. And I'm not talking about, I took 2 Advil for a headache, 2 years ago. That's not going to shut down my ability forever. But we tend to use in professional sports, we tend to use nonsteroidals a tremendous amount. I know in the NFL, it's almost standard of care to give Toradol shots before games. And as an NFL committee, for the pain committee, that's been one of our things that we've been trying to focus on, is to get teams and their medical staff away from doing that and trying to use other methods. And I understand that it works for pain. They work very well for pain. And if this is a Super Bowl game, I'm not really worried about, whether I'm going to degenerate over the course of the season, because this is it. This is the last game of the season. Sure, I understand why somebody would want to use them so that they can participate and play. On the other hand, if it's the first game of the season, why am I doing this? When I first started with the St. Louis Cardinals, there were 2 things that we did. We drank a protein powder every day. We just got it. It was imported free from this company. So we would have pallets of this stuff. And unfortunately, we were measuring nutritional value and not seeing a change in amino acids like glycine. Well, that's a problem if I want to heal. The other thing we were doing is every player, particularly the pitchers, was placed on some sort of an NSAID at the beginning of the season. This is prophylactic so that we can help them to heal. We don't do that anymore. We've seen our injury rate go down. When I was with the Oakland Raiders, we cut their games lost to injury in half, multiple mechanisms. But part of that was the fact that we kept the medical staff away from using nonsteroidals as often as we could. See the same thing when I was working with the Washington Wizards. We had one of the oldest rosters in the league, age-wise, but we were number 2 in terms of least number of games lost to injury. So the impact of resolution, I can't understate that enough, of what we see in terms of clinical effects on the back end. But these nonsteroidals are going to shut down production of these resolution mediators. And this was first seen, so we knew that this scientifically was being seen in animals. This was one of the first human studies kind of looking at this and taking this information and saying, okay, well, let's see. We're seeing that in mice and rabbits and, dogs and any other type of animal, but are we actually seeing this in humans? So in this study, they took 600 milligrams of ibuprofen, which is not a massive dose. But they were giving the 600 milligrams of ibuprofen to humans and saying, what's the effect? If I want to use this for delayed onset muscle soreness in an athlete that's starting to exercise, what am I going to see in terms of these pro-inflammatory but also pro-resolution fatty acid compounds? And it was a significant reduction in the production of pro-resolution mediators, which again is a problem. So we have to change the way that we think from blocking inflammation, from being anti-inflammatory, into thinking pro-resolution. Aspirin is an exception to this. And sometimes you'll see in literature that there's a little disagreement, that people will say, hey, for osteoporosis as an example, do nonsteroidal anti-inflammatory medications help, or do they cause a problem? And some of the studies that are positive are using aspirin as part of their discussion. Well, it's a little bit different mechanism because of the way that aspirin works, but it'll block cyclooxygenase 1, and it binds to the COX-2 enzyme in a specific manner that causes the production of resolution mediators. So you actually get a pro-resolution response by giving aspirin, but that's only in low dose. You can shut the whole mechanism down for the most part by giving too much. But the other problem with aspirin is that you will inhibit, because it is blocking the omega-6 conversion, you'll inhibit PGE2 manufacture, and you need PGE2 if you want an adaptive response in terms of training and muscle building. So you have to have that. So when we talk about giving antioxidants, but we're giving people NSAIDs, and we're saying that we're going to help you perform, we're basically ignoring the huge pole sticking out of my head, and we're focusing on the splinter. Both of them actually are issues. We've seen in studies looking at many different conditions where nonsteroidals are actually a problem. So if we're talking about muscle damage, doesn't help. Fracture healing, it's a problem. In fact, from a patient treatment perspective, in physical medicine, if I see somebody who is a burn injury patient, or spinal cord injury, or traumatic brain injury, but I also see it in athletes where they may have a deep thigh contusion, as an example, you can end up with heterotopic ossification or ectopic bone formation, which is a problem. How do we treat that? We give them nonsteroidal anti-inflammatory medications. Why? Because it impairs the ability of bone formation. So if I want an athlete not to get a fracture from an overuse injury, should I be using NSAIDs? No, I shouldn't. Again, I'm not saying that every circumstance is a problem, but just more evidence that it's an issue. Concussion and TBI, that's another one. It's even though we think of it as an inflammatory state, because it is, part of the secondary injury is inflammation, NSAIDs are not helpful for that. So the benefit in terms of what resolution mediators will do is they don't block the initial inflammatory response. So it doesn't prevent neutrophils from doing what they're supposed to do. It doesn't prevent me from getting off the court, right? What you want me off the court. But they do promote the natural termination of inflammation. So if I want a healing response to happen, the first thing is I got to get me off the court. I got to be off. So that full process, not just pull me over to the sidelines and have me stand on the court, but get me off the court. And so I need inflammation to work, but then I've got to replace me with somebody that actually can play. So SPMs resolve inflammation without compromising the immune response. That's what we're after. And then they promote tissue regeneration and repair. One of the questions I'm often asked is, if we're dealing with omega-3 derived compounds, can I just give EPA and DHA? And for that matter, can I just take alpha-linoleic acid? If I'm vegan and I don't want to touch any fish products, can I just do flaxseed oil? What we've seen is the actual, even though we have the enzymes that do the conversion, we have delta-5, delta-6 desaturase enzymes that do some of this conversion, we don't do it very efficiently. So we can't just use alpha-linoleic acid and drive up EPA or convert our EPA well into DPA and then into DHA. It's inefficient and it takes a long period of time. The same thing happens in terms of resolution mediators, particularly for people who have used NSAIDs chronically. They don't convert very well. Now, I still believe that people should be taking omega-3s or eating fish and getting them in the diet because they have other effects that are structural and they're important. Lowering triglycerides is one of those. But if I'm looking at a healing response, then nothing works better than SPMs. Now, the question that I'm often asked, are they safe? How do I know that they're safe? One of the things that the scientific literature has shown pretty clearly is that they're in every type of body fluid in the body, in every location. So they're in the brain, they're in placental tissue, they're in breast milk, they're everywhere through the body. In terms of studies that are comparing their efficacy for pain compared to standard treatments. This is an animal study, but there was a comparison done with Moresin, which is an end-state product. It's considered a drug, versus taking SPMs that are available, again, like through ProResolve. So if you take these resolution mediators, the efficacy was not quite as good as it would have been if you were taking the drug, but significantly better, improved compared to omega-3s. And comparing the response, the inflammatory response induced by lipopolysaccharides with animals, it was better than indomethacin, which is obviously it's a commonly used non-steroidal. We will see a problem with lipopolysaccharides as well in chronic NSAID users. Why do we get that? Because we get gut permeability problems. And this is not a discussion on gut permeability, but gut permeability is a problem. And why is that pro-inflammatory to have gut permeability problems? Because you will absorb, in part, lipopolysaccharide membrane, or the outer shell of gram-negative bacteria, which induces a significant inflammatory response. So we want to keep people healthy from a gut perspective as well. In terms of demonstrated efficacy, omega-3s, fish oil, eating fish, they have low potency compared to taking SPMs. And then ultimately, you'll see these things produced as drugs. And I was at a conference at Harvard about 2 months ago, and this was researchers from all over the world doing resolution research. And what you're seeing is a lot of the companies that have been, basically in charge of producing anti-inflammatory medications or looking at, let's say, immune modulating medications for things like rheumatoid arthritis, they are studying resolution, stimulating receptors, stimulating production of resolution mediators as sort of the next line of treatment. They aren't coming out and telling you, hey, you should probably stop using our products. That's not going to happen. right? But they are researching these things and saying, this is where healthcare is going to go, because that's what the scientific literature is clearly showing. So these are some studies, just clinical studies that you've seen, or that we've seen in terms of human trials, because that's another question that's often asked. It's, okay, it's great that it works in mice. Does it work in humans? Bet 80% overlap between mice and humans in terms of data and studies. I think with monkeys, maybe it's 95%. It's pretty close, but it's not 100%. So what about human studies? Well, human trials are being done, and there's trials being done on pain. We know that it changes, taking SPMs orally, taking Liponova has changed the immune response in people. So you'll see with taking these orally about a 4-hour change in the measurement of SPMs in the blood. And then you see a 24-hour shift in how your immune cells respond based off of that exposure to resolution mediators. You'll see this in studies in obesity and atherosclerosis have been done as well. And then a more recent study that was done here in Spain was the Gaudi study. And I'll get to that in a minute, but basically a placebo-controlled randomized study that was done looking at arthritis in retired football players. I want to say soccer, and that's not a good name. I don't even think it's a good name, and I don't live in here. My son plays soccer. It should be football. It makes no sense that we call football. You run with it, you throw with it, you don't use your feet for it unless you're kicking a field goal, but it's football. Anyway, with tendon injuries, we know that resolution is part of the process that is impaired with the development of chronic tendinopathies, whether we're talking about Achilles tendinopathy or we're talking about what happens with chronic rotator cuff problems. And obviously this is an issue. When I'm dealing with athletes in the pro baseball world, we have elbow problems and we have shoulder problems with pitchers. Even with non-pitchers, just field players, we see a lot of shoulder injuries. And we know that people who develop chronic problems have difficulty producing resolution mediators. And again, the standard of care, which is basically what we've talked about is taking NSAIDs, impairs our ability to produce these. So the Gaudi study that was done here was randomized, double-blinded, and placebo-controlled. And they were looking at the effects of SPMs on chronic pain, inflammation, functionality, and quality of life. This was with knee arthritis, so pretty homogeneous group. What the end result of the study showed was a significant reduction in pain through VAS, improved function and quality of life, and there were no dropouts or need for rescue medication. So a lot of these athletes were using Indocin or using some sort of a non-steroidal before the study. And they were told actually to stop for a period of time and then given either a placebo, which was olive oil, or they were given SPMs. And it's interesting to me, this was designed to be a 6-month study, but COVID hit and interrupted it, so it got cut short. But still showed significant impact even in half the time. So these subjects were followed for 12 weeks, initially taking 2 grams of the SPMs, which is kind of where I start with people if they've had an injury. Some athletes, we've gone beyond that. We had a player, kind of sidetracking here, but I had a player with the Oklahoma City Thunder, had an injury very early on in the season, had a grade 2 AC joint separation and a labral tear on his shooting shoulder. Well, that's going to be a problem, right? If you're a scorer, that's an issue. And what we did with him is we said, no NSAIDs. Of course, with his agreement, here's your options. You could take NSAIDs, you could take SPMs. Choose what you want to do, and we'll follow your lead on what you would prefer to do. And he chose to do SPMs, but he increased his dose on his own, kind of a typical athlete fashion that you see, right? Well, 4 is good, so 8 is better. So he bumped his dosing up to 8. He did 4 in the morning and 4 at night, and had no pain really through the season. Played really well, was in the top 3 in voting for MVP, and then had his surgery at the end of the season for his shoulder. So we see in terms of that high impact on somebody's ability to continue to play without them having to rely on resolution mediators. So anyway, back to this. We chose 2 grams a day, which is not a super high dose, but we chose 2 grams a day, or I didn't, but the study did. And then 1 gram a day was sort of after 6 weeks. So starting at a higher dose and then sort of a maintenance dose. And the results of this were that there was a 40% reduction in pain in the SPM group compared to a 28% reduction in the treatment group. So this would be enough to be considered a pharmaceutical impact. The other interesting thing to me is that the people were taken off of their nonsteroidals, which were helping them with pain, and you're seeing, there's always a placebo effect that things can get better, but it's interesting to me that the placebo group had an improvement in their pain over taking nonsteroidals, probably without all of the issues that we've talked about. Intermittent pain reduction, so you see a change in constant pain, intermittent pain, and total pain, about a 30% reduction. Again, 6 weeks, or I guess 3 months, but not the full 6 months of the program. At baseline, the patients that were using rescue medication versus at the end of the study and going back at the end, 70% reduction in terms of the treatment group versus just over 50% reduction or less than 50% reduction in the placebo group. So the conclusions, again, significant reduction in pain, improved knee function and quality of life, no dropouts or need for rescue medication, no adverse events. And most of the studies that are done that you see published using oral resolution mediators are this product. With Harvard, with Sirhan, there's some projects that I'm involved with that he does, and this is what we're using for these studies. If you look at pain response in general, this was a study looking at comparing or looking at, the physiologic response that happens with pain. Why do SPMs work? There's a presynaptic response and a postsynaptic response. So G-coupled protein receptors are affected by this, and I'll show you a slide on that in just a minute, but you see both central and peripheral effects with this. So the central effects on the nervous system, spinal cord level, preganglionic, postganglionic effects, and then nociceptive signal changes as a result of SPMs. So again, here, this was just looking at primarily Resolve in E and Resolve in D, but a change in what happens with nerve terminals. So if I want to have somebody basically have a healing response after a concussion, I don't want to impair my resolution response for obvious reasons now. But what do these do in terms of the NMDA excitotoxicity that happens in concussion? In fact, in an interview that I was able to do, there's a podcast that'll come out through IHMC probably in the next month or so. I got to interview Dr. Sirhan with Ken Ford, Dr. Ken Ford, who was the head of NASA for a period of time. So we interviewed him, just asked him questions about resolution. And these Resolve in D, Resolve in E, if they are present at the time of the injury, have a significant impact on recovery down the line. So they're preventative as well. But there's, again, the presynaptic and postsynaptic response changes that happen with these resolution mediators and reducing pain. What about sleep? So we know that sleep is a common issue. I know in the US, when we're traveling time zones, I'm sure it's the same in Europe, when you're changing time zones, you disrupt your circadian rhythm. But there are other aspects to this. I know with the NBA guys, with one of the teams that I used to work with, guys would come to me and kind of say, hey, what do I need to take? Because I'm going out after the game. I've just had 200, 400 milligrams of caffeine, and the game's over at 10:30, and I'm heading out. I'm going to go out and party. And then what do? Right? They're going to drink. And so they're asking for things. What can I take so that I don't feel hungover tomorrow before we catch our flight at 6 in the morning? Well, this is a problem in terms of sleep, and we're trying to discourage them from doing this. But one of the things that we see with sleep disruption with these athletes is they don't get the production of resolution mediators. So in this study with sleep disturbance, this was kind of the first investigation within the last 2 years that kind of showed this. So if we have night shift workers, that's a problem in terms of resolution. Night shift workers have more problems with obesity, diabetes, hypertension, cardiovascular disease, neurodegenerative disease, cancer, name it. They have more problems with it. So SPMs are produced. And in this study that was done at Harvard, they noted that the non-REM sleep was really important. So the first 90 minutes of your sleep and your typical circadian rhythm is where you're going to get most of your production of resolution. And so if you're interfering with that process, then you don't get a healing response. So what does alcohol do? I mean, I know that that's not a direct discussion on SPMs, but it's really important. What does alcohol do to deep sleep? It disturbs it. So your non-REM sleep is disturbed. So if I have athletes who are, like to go out and party, I kind of talk to them about this. Like, yeah, you're increasing your risk of injury. Why would that be? Well, because you're not sleeping. Well, I can sleep later. But you're disturbing your sleep-wake cycle. So your deep sleep is disturbed. And what do we do with athletes? We're trying to get them into a normal pattern of sleep. We're trying to monitor sleep. We use Aura rings with people a lot of times. The NBA used the Aura in the bubble. So they were tracking temperatures and heart rate variability and looking at sleep scores. Not that it's perfect for looking at deep versus your REM sleep, but at least you have some sort of an idea of somebody's sleep architecture. And the non-REM sleep is where you're going to get the production of resolution mediators. It's also where you're going to stimulate things like growth hormone production. And then, if your deep sleep is disturbed, you have less testosterone production. That's been pretty well documented as well. So in this study, the data, again, conclusion, this data suggests that during recovery from sleep disturbance, non-REM rather than REM sleep promotes inflammatory resolution. So that's what we're after. This was a study looking at vagus nerve stimulation. Dr. Serhan did this. And what they were doing is directly stimulating vagus nerve function. And you'll see devices that can be used. Alpha Stim, there's something called, in the US, called David Pro, which stimulates an alpha wave response. There's direct vagus nerve stimulation that you're seeing used for patients with anxiety. We use it sometimes with athletes that have performance problems, right? They get anxious. Can you stimulate the vagus nerve? So what ultimately is what we're after is we want parasympathetic function. And if we have parasympathetic function, it turns out it promotes a resolution response. So everything that we use to try to promote a performance benefit comes back to the same thing. We want parasympathetic function balance. We want a balance between catabolic and anabolic function. We want a resolution response. What about remodeling? We know that during the course of a season, if you're tracking an athlete using a DEXA scan, you're going to see an increase in body fat mass during the season typically, and a decrease in muscle mass. But we also see in aging animals that there is a loss of production of resolution mediators in muscle, and then gradually there's a loss of the ability to recruit stem cells and satellite cells to have muscle protein synthesis and building muscle. So it's more than just giving enough protein, which is an important piece. You can give them branched chain aminos and leucine, isoleucine, and valine to promote that. You can give them creatine to help with muscle protein synthesis, but you have to have a pro-resolution response. And so this is just showing, kind of hard to see a little bit, but you can see the left versus the right side with a little bit of fatty infiltrate in the aged muscle. Again, we got to change thinking from being in a anti-inflammatory thought process into being in a pro-resolution process. That's key to performance. And having a resolution focus, why do we want that? Because we want to resolve and reduce pain. We want to shorten the time to having a healing response. We want to lower oxidative stress, at least have a natural response to oxidative stress so that doesn't become destructive and inhibit things like nitric oxide production and neurotransmitter function. We want to clear cellular debris because we don't want to be in a chronic inflammatory state. We want to regulate mitochondrial RNA function and have good energy production. We want to maintain muscle mass. So if we're taking SPMs, we have a 4-hour window where you see a significant increase in the number of SPMs in the blood, followed by a 24-hour change in the immune response. So this is going to help us with recovery. And major lifestyle takeaways from this, simple. We want to promote sleep. We want to get deep sleep. We want to have the right type of training and exercise and periodization. We want to have good nutrition. Not just focused on calories, although calories are important. We need macronutrients and we need micronutrients. We want to mitigate stress. Sometimes we're stimulating a parasympathetic response or having a vagal response. We're promoting resolution, which is important, and limiting environmental disruptors that can cause a chronic problem with oxidative stress or inflammation or with energy production. And so these are some of the things that could potentially be used. CBD boswellia have studies that show that they have a positive effect, not quite the same as taking resolution mediators. Taking omega-3s, do they have an effect? Sure. With balancing omega-6 to 3, you get a benefit, but taking the resolution mediators has about 100 times the response that you would see in terms of your ability to heal versus taking omega-3s. And then avoiding NSAIDs. You're not always going to be able to skip them or not use them, but in general, they should be few and far between and very limited in their use. In professional sports, what we're seeing is about half of the teams in Major League Baseball and in the NBA are using SPMs in general, but about 90% of the teams that end up in the playoffs are using SPMs. And one of the interesting things is in the NFL, Gatorade owns the rights to supplementation. So when I was working with the Raiders, we had to be really specific about our request for need. So I can give any Gatorade product that I want to, but giving something else had certain rules and regulations that I had to get around. And so you have 20% of the teams in the NFL using SPMs in spite of the fact that Gatorade owns the rights to all of it. But you have to prove a medical need. I think that that'll grow. But about half the teams in the NFL playoffs are using SPMs. So it's growing and being used. It's not on billboards everywhere. It's mostly word of mouth, and you're seeing people reach for them more and more. One of the common things that I see is when a player leaves a team, I get a call from the new team. So I have somebody that leaves the Washington Capitals, and they go to the Vancouver Canucks. I get a call from the team physician. Hey, you had a player that was with you, is now with us, wanted to use a product, said he saw great results, was helping the guys. How do I get this? In fact, with the Capitals, we were the first team in the NHL using this product. We got samples, and this was in 2018. So our roster's a little older now, which is kind of a problem. We were surprised to make the playoffs, but at that point in time, we hadn't really been over the hump to make it into the Stanley Cup finals. And we ran out of samples right before the first game against the Vegas Knights, and it was like mutiny. So frantic phone calls and reaching out, trying to get more samples, and we got them for the second game. So whether that's placebo effect or not, a big shift in the attitude of the players with confidence. And typically just have less soreness and pain. That's what we see. So they're able to push themselves more. So any questions as we kind of wrap things up here?
I lead a pain unit in Madrid, and I was using Lipinova in the. Thank you. I was using Lipinova less for a year in the last several months. A question about CBD. Sometimes I combine CBD with Lipinova from ProResolve in order to the synergistic effect. But you told us that you have a difficult with the sport game. Okay. What do you think is the role of the sensible sun exposure? Because when you have an exposure to the sunlight, you express endocannabinoids, so it's similar to CBD. So maybe it's a way to improve the effect. What do you think about that?
Yeah, I think very likely. Most of the things that we think of as positive lifestyle factors that improve health are promoting resolution. So, light exposure, getting sleep, exercising. So in terms of pain, you probably see that with your patients. Somebody who is inactive, stays indoors, they get depressed, makes their pain worse. Their diet isn't great. their pain will be worse, right? So you're improving some of those things in addition to what you're doing in normal interventions. You should see more improvement with your patients. And again, the goal is to promote resolution. One of the interesting things is that corticosteroids don't have the same effect as NSAIDs in terms of being completely blocking the inflammatory response. There's a small pro-resolution response with those. And I don't know a lot about it, but that was something that was discussed at that last resolution conference, which was very surprising to me.
Hello.
Hello.
Last quick question.
Yeah, Josep Bergés from the Observatory Foundation International. Well, thank you the same. I learned a lot in your speech. Thank you. I have 2 comments, or what do you think? No? Because we, in the Gaudi study, we study on the knee way, no? Do you have experience in your clinical practice in other joints? Because the physiopathology of the joints are very different, no? You know, that knee or for example, fingers, another problem that you have. What do you think? Would be possible that other joints works, no? And secondly, one of the things that for me, because we are treating patients with OA, that means that's a chronic disease, no? One of the good things that you mentioned here is that the safety of the product, no? Because you can use the product won't have any problems, no? That's very important, no? But you know, in your experience, you are using more in acute treatment, no? More in players, no? Do you think that could be different? What is your feeling about that, please?
So, yeah, in terms of osteoarthritis, if I'm dealing with somebody who is end stage, and I'm trying to just prolong them from the end state, let's say a knee replacement or a hip replacement, I'm willing to use non-steroidals, but I also give them SPMs. And I see a bigger pain response with that. And I do think that within, not just within the knee, I know that there's a little bit different mechanism, but you still have neutrophils and macrophages and changes, the class switch that is happening to promote a healing response. And you'll see that resolution is, the production of resolution mediators is important in any joint and in every process.
I have another question. If you
I think that's a wrap. Right. Thank you very much for your attention.
I'll talk to you after. Sure.
So first of all, thank you very much for your clear and structured presentation that let me underline how you explain the concept in order to understand the active natural solution of inflammation processes and the recovery mechanism to reduce the pain. This is really affordable, and thank you for this clear explanation. Also, you introduce the Gaudi results that are very exciting results in terms of statistics, with 45% of statistic solutions. And to add to these clinic results, I would like to introduce a little history that in one of the teams you support and you work as a consultancy. A few months ago, one of the most quarterback famous in America called our office, Azure office in America, and he requests to buy this material, and this Lipinova. And of course, the people that support the call request him to, why do you need to buy this? Because this is one product that your clinician, your specialist in your team give to you free and under prescription, if you like, right? So but I say, I feel better when I consume this product. But what do you mean I feel better? So in the last year of my life, I consumed 2 paracetamols a day before training, and I stopped to do it. I consumed this material and my pain has been reduced dramatically. And I would like to recommend this product to my brothers, my friends, because really it works. And of course, we cannot explain more details about this because this is under a non-disclosure agreement with the team. But this is something that was real work and really happened in the big athletes in America. This is, I would like to add to your nice and clear presentation. Thank you.
Please, a round of applause. Thank you very much.